My name is Shelley Cohen-Conrad, and I am the director of our Interprofessional Education Collaborative. And I'm really happy to see you all here. I get to do the boring logistics and then introduce the exciting people who are here for our presentation today. All of you who have been here at IPEC events know we just ask you to fill out the card. We want to know who you are. Some of your programs want to know you showed up because you're required to be here. And then we have questions on the back we would love you to answer because we're really trying to constantly do improvement on our events and activities that we do through IPE. Also, you know that we draw from our information and we give a gift card to a student who has attended. And I don't know whether Sarah Goslin is here today, but we have a card for Sarah Goslin from nursing. And are you guys nursing students? Can I give this to you to give to Sarah? Great, thank you so much. So what I'd like to do, because we have so much great information today, is to turn this over to Toho Soma. The Interprofessional Education Collaborative is co-hosting this with the Center for Excellence in Health Innovation. So please let's welcome Toho to the stage.
Thanks, Shelley. Welcome, everyone. I'm so glad to see such a huge turnout today for what is obviously a very important topic around opioid use disorder. As you probably all know, Maine averages about 1 overdose death per day, the majority of which involve opioids, so it's certainly a health crisis that we all need to play a part in. So I'm happy to welcome two people from the community who are doing amazing work, and I want to showcase what they have to offer today. So please welcome Zoe Odlin-Platt. She's a community health promotion specialist at the City of Portland's Public Health Division, and she oversees the Portland Exchange out of the India Street Clinic. And then Dr. Cameron Bonney, who's a psychiatrist at McGeechee Hall, and McGeechee Hall is the outpatient psychiatric clinic part of Maine Med. So please welcome both of them. Thanks.
Hi, thank you everyone for being here in this nice new space. We wanted to kind of just get an idea of who's in the audience. So Toho, I mean, you might need some help with the different schools, but can we just know like who's here representing which department?
Pharmacy school.
Nice.
All right. Social work.
All right.
Any osteopathic medical students? No. Any, what else?
Nursing. Nice.
PT.
Yeah, physical therapy.
Physical therapy.
No. Oh, cool.
We did that.
Sorry, I think that was like,
That's good.
that was everyone. That's great. That's really cool.
So our next question is, who here, and if you don't feel comfortable raising your hand, that's fine, but who here has been personally affected by somebody who uses opioids? A lot of hands. Thank you for having the courage to do that. Who here thinks they will not be affected in their professional life by opioid use? Good. Okay. Nobody should have their hand raised because, unfortunately, this problem is all over the place. So,
we're going to try to set a quick foundation of harm reduction for folks who don't have a lot of understanding of what it is as a philosophy and how to incorporate it into any of the work that you do. So, these are some of the objectives we're going to cover today. I think most of you are pretty aware of that. You know, we're really going to talk about the foundation of harm reduction, then Dr. Bonney's going to get into his work, and then we're going to talk about overdose prevention and try to do some hands-on naloxone administration. So we'll see how that goes. What else? Got all this
oh, okay, I was going to do this one.
Yeah.
So a brief review of some of the terminology. I think people are generally aware of the quote-unquote opiate or opioid crisis, but you might be wondering, when did we start calling them opioids, and what's the difference between an opioid and an opiate? For the pharmacists in the room, you probably already know, maybe the physician assistants. An opioid is defined as any molecule that binds the mu opioid receptor in particular, and is an agonist or a partial agonist at that receptor, meaning it activates it. An opiate is morphine and its derivatives, so morphine, diacetylmorphine, which is heroin, or codeine, okay, and its natural derivatives. So it comes from a plant. It comes from an opium poppy. You'll hear terms thrown around: addiction, dependence, use, abuse disorder, opioid use disorder. So the term addiction is a general term. It's a cultural term. It describes various patterns of substance use that are compulsive and often harmful. Dependence and use are the terms, dependence, use, or abuse are the terms that are still used in the ICD-10 language, which is an international classification of physical and mental health conditions, and was formerly used in our DSM-4, which is the Diagnostic and Statistical Manual for Psychiatry. And they used to have a distinction between abuse and dependence, that some people who had less severe symptoms were diagnosed with abuse, and then with more severe symptoms, you got diagnosed with dependence. What DSM-5 tried to do when it came out a couple years ago was to acknowledge that there's a spectrum of substance use, and that at any point it can cause problems, maybe more or less problems. And what it really does is it allows healthcare providers to intervene at any point along the spectrum. So just to clarify that, when in harm reduction circles, and in healthcare circles in general, I think you want to avoid terms like addict or user. I think they have pejorative connotations. The terms that we like to use always begin with people. So we talk about the person first, and their behavior or their condition second. So people who use drugs, PWUD, or people who inject drugs, PWID. And you'll see that all through the literature on this subject. All right, so I'm going to turn it back over to Zoe.
Okay, so just, again, some of you may know all of this, but this is a definition that I like to use, and it's according to the Harm Reduction Coalition, which is a great resource if you're interested in harm reduction and learning more about it. But it really is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use, but not always. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. And again, I say that, this is the Harm Reduction Coalition's definition because as the coalition, they are working with people who are actively using and, working towards policy change and all of these other incredible things. But harm reduction can really be used for a whole variety of things, not just for people who are using drugs. But I like this definition. I think it makes a lot of sense. And I think that it's something that when you learn more about it, it's just sort of like, for a lot of people, it just clicks. And it's just like, oh, of course, like that, why wouldn't we just be nice to all of the people that we work with and treat everyone the same? Everyone deserves to be healthy and safe. Goes along the lines of that. So it's also something that we consider realistic. It meets people where they're at, and we'll talk about that more in a variety of ways. It's low barrier. It's, for people wherever they are at, ultimately. It's hopefully always free of judgment, which can be really, really hard as a provider, as a counselor, as any type of person in this work. It can be really hard to put our stuff aside when we're working with people. And it's not abstinence-based, ever. But it's also not about illegal substances all the time. So it's this really interesting balancing act of working with people, helping them to feel empowered through education, through the knowledge and the support that we provide to make positive change for themselves, however they identify that change to be. So again, being mindful of our own judgment or our own beliefs, what we think somebody should be working on versus where they're at and what they're ready to work on. And I think it can be really challenging, but really, really important to try to do that. And so when you think about these other things, you know, somebody who wants to work on their eating habits or, you know, not smoking so many cigarettes or weight loss, exercise, any of these things, you know, making that goal something that's realistic for them, something that makes them feel like they're in control of that decision, and we're not putting our own agenda onto it. So you can think about that in a variety of ways. So this is sort of the question that can always be asked, like, what is the most immediate, realistic option for the person right now? What are they identifying that they want to work on? You know, so when you think about needle exchange, the work that I do, you know, for some people, they're like, well, you know, the goal is recovery, right? Like, don't you want everyone to stop using? And I say, no, like, not really. For some people, that's their goal. But my goal is to keep them as safe as they can be today so that they can be here tomorrow, and they can continue to work on the things that they want to work on. A lot of the times it's other things. Housing is huge. Primary care, mental health needs, you know, connecting people with services. The population that I see oftentimes is not accessing medical care or mental health services or case management services on a regular basis because of everything that's associated with their substance use sometimes. So what do they want to work on today? Sometimes it's just like a clean pair of pants and somebody to be nice to them, and that's okay too.
I just want to throw something out there that I've been finding myself saying more and more, which is that you can't stop using drugs, any drug, if you're dead. So keeping people alive allows them to achieve recovery.
Mm-hmm. Absolutely, yeah. So, and sometimes it's that simple. Sometimes it is just helping somebody stay alive today. I mean, sometimes it is just sitting with somebody after you've reversed an overdose that they've experienced and just helping them through that, because that's all that they're going to kind of be able to accomplish. You know, those are their words. That's all they're going to be able to accomplish today. And that's okay, as hard as that feels. Okay, so things that they do and don't do. You know, it's really become clear, and I think all the research and the data is showing that. Everyone's hearing about it. It's all very hot topic items right now. You know, we know that needle exchange programs do not encourage drug use. They do not enable people to use drugs. People are using drugs regardless of if they have clean needles. We know that. You know, it doesn't increase criminal behavior. That happens with or without needle exchange programs, or any other harm reduction based program. I'm just using mine as an example. And they also don't exist at odds with other sort of treatment focused or AA or 12-step focused programs. It's just, we're all kind of here doing the best that we can with what we've got. We know that our program, we do have data on sort of reducing HIV and Hep C transmission. We've only had 2 people in our program test positive for HIV since 2012. Hep C is a tricky one because there's so much Hep C in our community. But we have a very low rate of people testing positive once they've started in the program. So about an 18 to 20% positivity rate of people, once they've enrolled in our program, are then testing positive for Hep C. And that's well below the state and national average. So we're very proud of that. We know that our program is preventing overdoses. Last year in our program, our clients reversed 291 overdoses. So that was our clients reversing overdoses, you know, their peers in the community. So that's potentially 291 lives saved. Reducing needle waste, of course. Here in Maine, we're a 1-for-1 exchange, so people have to bring their dirty needles in to get clean needles, so it's a good incentive to have safe storage and disposal. And they serve as a gateway to resources. I mean, so much of what we do all day long is connecting people. You know, the reason why we're both standing here on this podium is because we work with so many of the same people, and we're always connecting and making sure people have access to what they need. So why do people use to begin with? I think, you know, people use drugs for a reason, and there's a lot of different reasons. For some people, it's just coping, it's distraction. It starts out as something that's fun and interesting. Drugs feel really good, so people use them because they feel good. And then sometimes people become dependent on them, and there's a whole range of what that dependency can look like, and we'll look at something in a minute. You know, the environment that people live in, what's around them. You know, we see a lot of generational drug use in our exchange. So, you know, we see children come in with their parents and their grandparents and their aunts and their uncles, and everybody's using. You know, pain management, huge. Since the pendulum has swung in the other direction of people prescribing opiate pain pills, we are now seeing a lot of people who come in because their pain is not being treated properly because they have doctors who are so afraid of prescribing pain medication, or pain clinics are closing, or they lost their main care, or they don't have any health insurance, any primary care, all of those things. We see, you know, here in Maine, we have a lot of people who do really hard work. We have a fishing community and, you know, hard laborers, roofers, and landscapers, and like, you can't just not go to work, so you have to work through the pain. That's a very real one here. Of course, things like genetic predisposition, you know, again, sort of the environment can tie into that, I think, a lot of times. And I really think, and I really encourage anyone, because every single person in this room will at some point work with somebody who is using substances. You know, I learned everything that I know the first year in the exchange by just asking people why they use and what they use and how it feels and how they do it. You can gain incredible knowledge and build incredible trust with clients and with patients if you just ask them why, and then really actually listen to what they have to say. So this is what I was talking about, and I think, you know, Dr. Bonnie touched on this a few minutes ago too. I think it's important to remember that not everyone's drug use is where we think it might be placed on the scale. I think sometimes, like, we'll place it somewhere else, and then the person will identify, you know, like, my drug use isn't chaotic at all. It's everything else in my life that's chaotic. My drug use is actually just very recreational and, you know, does not get in the way of some of these other things I want to work on. It's all of the other stuff, you know, the lack of resources for a whole other variety of reasons, or the fact that my case manager has changed 10 times in the last 6 months, or there is no affordable housing in my community. Or my mental health is so severe that I'm self-medicating because that's the only thing I know how to do, because I'm not sort of fitting into the right box. So I really like this continuum. I think it's helpful to think about. I think it's helpful to ask people where they would place their drug use. You know, how does it feel to them? And of course, then there's always like the myths that we all hear and that people say, you know, that people who use drugs don't care about their health, or like they're too busy getting high to go to their doctor's appointments. I think we've learned that that's not always true. There are just people who just don't go to their doctor's appointments regardless of their drug use. You know, people who use drugs can't manage medication routines. Well, I think a lot of the Hep C research that's been coming out disproves that as well. You know, there's Hep C treatments that we're finally finding that people can actually still use drugs and treat their Hep C and take their meds every day. You know, they're only interested in drug seeking. You know, if they're showing up at the hospital and they're saying they're in pain, like, they're only drug seeking. It's impossible for somebody to use drugs to actually also be in pain. And then, of course, this one I think comes up whenever we talk to people. I mean, I see a lot of people who will not go get their health condition checked out because they're so afraid of the interaction at the hospital, which is a very real thing that happens. You know, somebody who presents at the hospital with an abscess or a skin infection, like, they are being treated differently a lot of the times than somebody who is there. You know, if I walked in for strep throat, or, you know, you walked in with a broken ankle, like, it feels different.
So I think I'll take over for a little
Yeah.
bit here, but I wanted to open it up. Are there any questions right now? There'll be time for more questions later. Anybody have any burning questions? So how does the practice of harm reduction relate to medicine? It's been my belief, and is my belief, that pretty much all of medicine is harm reduction. You know, there's the old saying, primum non nocere, first do no harm, attributed to the Hippocratic Oath. It's not, it became popular in the 1700s. But in any case, this is what we as providers are, as physicians, are charged to do, is to maximize health and reduce harm. And the kind of interventions that Zoe and her colleagues provide are not at all controversial in infectious disease circles, in internal medicine circles, in hepatology circles, in HIV/AIDS. But somehow, when you get into the folks that are supposed to be working most closely with them, people that specialize in addiction, it becomes controversial. And there's various reasons for that. But I think that harm reduction and medicine are natural allies and partners. I'd invite people to think about what we're actually doing for those people that are familiar with prescription medications and their effects on the body. What are we actually doing when we're treating medical conditions with prescription medications? Most of the time, I would argue, we're not treating the actual condition. We're reducing the harm that the condition causes for the person. Okay, so some examples are antihypertensives. If you have high blood pressure, your doctor might prescribe you something that lowers the tone in your blood vessels, that makes your heart beat a little slower, that makes you get rid of a little bit more water out of your blood. And all of those things are going to reduce your blood pressure, but none of them are going to fix the fact that you have high blood pressure, because you are a human being and you're getting older and your arteries are becoming a little more calcified, because that's what happens. And behaviors can alter that, as we all know, but ultimately, the interventions that are most effective are things that reduce harm. Statins are another one. Statins are drugs that are used to lower cholesterol. You can go on an ultra-low lipid, ultra-low cholesterol diet and lower your cholesterol, but most people aren't able or willing to do that. And so they get prescribed a statin. Okay, this is mainstream. This is antidepressants. People don't get depressed because they don't have enough antidepressant in their system. Okay, and I'm a psychiatrist. I think I can attest to this. It's not even that they don't have enough serotonin or any other neurotransmitter. Most people who are depressed have normal levels of serotonin. Antidepressants are used to treat the symptoms of depression. But depression could be multifactorial. Lots of different things can cause depression, so most of which we're not really that familiar with. Even insulin, I would argue. Insulin is naturally made by the body. Insulin is prescribed to treat diabetes if somebody's not making enough insulin. But if you are diabetic and you need insulin, no amount of taking insulin is going to replace the fact that your pancreas doesn't make insulin. Okay? And you're going to have worse health outcomes than if you did have a pancreas that was working normally, even if you have well-controlled diabetes on insulin. So some things to think about when we're talking about how we use medication to treat a substance use disorder. It's really, really similar, in my opinion. A lot of the harm reduction research dates back to the epidemic of HIV/AIDS. We really didn't start, as a medical community, we really didn't start to get a handle on the spread of HIV/AIDS until serious harm reduction measures, including needle exchanges, were implemented. And also the dawn of what used to be called opioid substitution therapy, pretty self-evident. You, instead of using heroin, you prescribe another drug to somebody that is less dangerous so that they can get on with their life. They don't go into withdrawal. They can use a measured dose of the drug and continue. So now we call this medication-assisted treatment. Okay, it's a little more palatable, I would say, to some of the naysayers, because people go, but what about the counseling? What about the psychosocial interventions? And we'll get to that in a second. What medication-assisted treatment implies is that there's an overall treatment program, and that medication is a piece of that. And I believe that is the best practice. But as we'll see what the most important piece is. Harm reduction is endorsed by national and international health agencies, the World Health Organization, UN Office on Drugs and Crime, SAMHSA has all these hard, we're not doing what our own agency, SAMHSA, says to do, which is be liberal with your prescription of Suboxone. Get everybody on methadone. If you're get people on these life-saving medications. We're not doing it. We have very high barriers for treatment, and it's not just here in Maine, but it's particularly a problem right now.
I'm gonna go sit while you do this.
Yeah, okay. So moving into our second part of the presentation. So what do you do for somebody if they do want to stop using opioids? What do you do if they, have been buying illicit painkillers, pills on the street, or heroin, and they're ready to do something different with their life? What kind of intervention can you offer them that's going to help them stay off of illicit opioids and help them be safer and healthier and more productive in their life? So just kind of a brief history of opioid use in the United States. This is not a new drug, of course. It comes from the opium poppy. Laudanum was something that Ben Franklin was well known to use pretty much every day while he was writing the Constitution and stuff like that. It's a combination of alcohol and opium. Morphine was isolated in 1805. In 1844, the hypodermic needle was invented, which was just in time for the Civil War. A lot of people became addicted to opioids during the Civil War, where they were administered for pain control with these horrific injuries that people had on the battlefield. In the 1850s through the 1920s, a lot of medicines that you would buy over the counter, these so-called patent medicines, would contain morphine among other drugs, including cocaine, cannabis at times, and a lot of other stuff that didn't do what it said it was going to do. It was usually just alcohol and morphine, and it got you intoxicated. Heroin was invented in 1874. There's some story that maybe it would help people get off of morphine. That didn't turn out so well. 1914, the Harrison Act. So this was really important, and this has changed the way that we treat treatment of people who use substances in the United States. In 1914, there was a law that was passed that was the first law that regulated opium and cocaine. So this is a precursor to today's drug laws, today's DEA, and so forth. And what it said basically was that only a doctor could prescribe these certain substances, and only for certain conditions. And a doctor was arrested after this was passed for prescribing a handful of cocaine tablets, which were available as tablets at the time, and some morphine to somebody who was known to be addicted to both and was suffering. And he said, I want to treat their withdrawal, and was taken to court, and it went all the way to the Supreme Court. And the decision was that doctors became specifically prohibited from prescribing opiates to treat addiction. That continues to today in the United States. Now, there are exceptions to this rule, but I cannot prescribe anything other than buprenorphine. I can't prescribe morphine, I can't prescribe oxycodone to relieve somebody of their withdrawal. Okay, this is very well, tightly controlled. The first methadone clinic was in 1964. It was attached to Rockefeller University in New York City. They had a heroin epidemic at the time. They were looking for something. They had no interventions that were effective. They knew all the psychotherapy and all the groups and all the, that was the big heyday of psychoanalysis. All the kind of intensive treatment in the world would not help somebody to not use heroin. And then I referred to these waivers. So in 2000, the Drug Abuse Treatment Act is the act that allows doctors under certain circumstances to provide buprenorphine, also known as Suboxone, for the treatment of opioid use disorder, formerly called opioid dependence. Okay? Prior to that, methadone clinics were legal, but there was a laundry list of conditions you have to meet to be a legal methadone clinic. All right, so I'm going to take a hand poll here. Don't be shy. And I've listed a whole bunch of things up here on the board. Please raise your hand as I go through them, and raise your hand if you believe that this might be an effective treatment for opioid use disorder. Okay? I need a drink of water, though. Okay, number one, cognitive behavioral therapy. Methadone. Narcotics Anonymous. Okay? I'm just asking you to raise my hand. I'm not. Vivitrol, which is a long-acting naltrexone shot. Anybody? Okay. Hypnosis. Psychoanalysis. I kind of threw that one under the bus with my last comment. Medical detoxification, meaning you go somewhere like Milestone and get detoxed and then discharged. Okay. 30-day residential treatment. Sober living, meaning you can come and go. Buprenorphine, whether as Suboxone or a closely related medication called Subutex. 90-day residential treatment. Okay. Strict criminalization of opioid possession. Make the laws tougher. No. Diacetylmorphine, which is heroin. Okay. Levomethadyl acetate, which is LAAM, which is no longer available. Okay. Naltrexone, oral, taking naltrexone pills. Now, this is, for those that don't know, this is an opioid blocker, similar to the Narcan, the Naloxone that we're going to be talking about, that's orally bioavailable. Intensive outpatient programs. Okay. Smart recovery. Anybody heard of this? It's a CBT-based 12-step alternative. People meet in groups. Oral naltrexone's on there twice. Sorry about that. Extended release oxycodone. Okay. Licensed alcohol and drug counseling. Okay. Mandated treatment in lieu of going to jail or something like that. Ibogaine. Anybody ever heard of Ibogaine? Okay. Ibogaine's a psychedelic drug from Africa that has some kind of case report literature on people being relieved of their addictions after single doses, but not enough evidence yet, Zoe, sorry about that. So here are the actual real ones. There's 5, okay? Methadone, long-acting Vivitrol, depot injection, buprenorphine, heroin. How can that be? Well, it's special clinics. All of them are in Europe. If you keep using heroin, even though you're on methadone and you're stable and you're housed and you're doing okay, you can go to a clinic and get an injection of heroin twice a day. And it's clean. There's healthcare professionals there. You don't get Hep C, you don't get HIV, you don't engage in crime, you don't do the things that are the negative consequences of drug use. So that's kind of harm reduction in a nutshell. This LAAM had some bad side effects, but it's like a longer acting methadone that lasts for 2 days. So you could do every other day dosing. Oops. Okay. There's 5. Yeah. That there's lacking research? Yeah. I think it's both. But I would just, the point I'm trying to make here is that all of our effective interventions include the use of medication. Okay? And you say, how can that be? I know so-and-so, my cousin kicked the habit and they stayed sober. In medicine, the way we evaluate interventions is, the effect of a placebo or no intervention versus a particular intervention. And so what the research has shown time and time again since the 1960s is that all psychosocial interventions without the use of medication are no better than no treatment at all. That might be hard to hear. Okay, this is specific to opioid use disorder. But I think it's important for people to know this and to realize this. A lot of our sober living houses here in Maine, there's only 3 that I know of that accept people that are on Suboxone, evidence-based treatment for opioid use disorder. So for a lot of people, they have to decide if they want to go live with a bunch of people that are also trying to not use drugs and participate in the program. They have to come off their Suboxone. That doesn't make sense. None of the residential treatment have ever been shown to be effective in the long term. In fact, with medical detox, 30% of people, the day they walk out of detox, will use. 30% of people. Okay? So really important. So all effective treatment for opioid use disorder, I would argue, is based on harm reduction principles. We don't require people to abstain completely from opioids necessarily, but we do hope to, by altering the way they use their opioids or their opioid blockers, to be able to make healthy changes in their life. So there's no evidence for any psychosocial intervention alone in opioid use disorder, no evidence for any specific psychosocial intervention in combination with medication. There's been a lot that's been written about methadone plus motivational interviewing or methadone plus cognitive behavioral therapy. No particular intervention seems to be more effective than any other intervention, but that said, the reason I put an asterisk there is that every methadone program has some sort of basic counseling woven in. So you can't do a study where it's just medication. There are very few studies that are just, here you go, there's a prescription, see you later, okay? All right. Did that answer your question, kind of? For the guy in the back? Kind of, sort of. Well, come back to it if I don't answer your question. Something to bring up is contingency management. People heard of contingency management? So that looks like something that may be better than some of the other psychosocial interventions in conjunction with medication, but I don't think there's enough evidence to say that. Contingency management is where you pay people to not use drugs. You give them rewards. Okay, you earn a gift certificate if you come in for your weekly meeting and you haven't used drugs, as evidenced by your urine drug screen. So if you remember nothing else from this talk today, please, evidence-based treatment for opioid use disorder equals medication. Okay, evidence-based treatment equals medication. This is not controversial in the addiction literature. It's not controversial in the medical literature at all. So let's talk about the medications that are available. And Zoe, I think I can maybe take 5 or 10 more minutes. It's just about before 12:45. Okay. So in the United States, we have 3 of these evidence-based treatments available for the treatment of opioid use disorder. The first and most effective and the longest available is methadone. So methadone was synthesized in Germany before World War II. It came to the United States as Dalmane, I believe, a long-acting painkiller. And as I mentioned before, at Rockefeller University in the 1960s, they decided, let's just see. It was used for detox before that. But what would happen if we just kept people on methadone? And they found that people's lives got better. They stopped engaging in crime. They went back to school or to work. They didn't spend so much time trying to obtain and use drugs illicitly. So in the USA, methadone is tightly regulated, as I said before. There's daily observed consumption in specially licensed clinics. Here in Portland, there are 3. There's Discovery House. There is, help me here, Zoe, sorry. Merrimack Clinic and CAP Quality Care. Has a long half-life, only needs to be dosed once a day, so you don't go into withdrawal until well into the next day. It's a full agonist at that mu opioid receptor, as I mentioned before. So equivalent to heroin, morphine, and other drugs that people might abuse, it has the same pharmacological action in your brain. And overdosing is possible on methadone. It happens. People are 4 times more likely, from one study I saw, to overdose in a combined drug overdose if they're on stable methadone maintenance than they are if they're on stable buprenorphine maintenance, which is the next medication I'm about to address. Questions about methadone, anybody? People can get take-homes, which if they are having a lot of progress in their recovery, they can earn the right to take a few doses home with them. So like you don't have to come in on the weekend or something like that. That's an incentive. There are exchange programs, but it really does kind of limit travel. You could imagine if you have to go to the same place every day, but you want to go visit grandma in another state. It can be really tough. You have to plan ahead. There are drug-drug interactions for some of the pharmacists in the room between methadone and other drugs. It prolongs the QTC. So it can be problematic for that reason. Okay, so the next medication, the next of the 3 that's available in the United States is buprenorphine. brand name Suboxone or Subutex, some others, Zubsolv. What am I missing? Bonavail. Okay. So buprenorphine, what was revolutionary about buprenorphine is it allowed any doctor, not just a methadone clinic, not just an addiction specialist, any doctor who goes through a certain amount of training, it's an 8-hour or 12-hour training, I forget, can then prescribe buprenorphine for the office-based treatment of opioid use disorder. So you can, the intent was to go to your regular doctor and to get some medication to help you not use heroin or whatever other opioid you were using. You are required by the law to be able to refer to counseling if medication alone is not enough. And of course, a doctor, during the course of the doctor's visit, we would assume there would be some kind of basic level counseling. But this is low barrier stuff, guys. It never was intended to be this huge thing like it is today. Prescribers need a special waiver. You can prescribe, the first year you can prescribe to 30. After 1 year, you can ask the DEA to allow you to prescribe to 100. And if you are a addiction medicine specialist, it can be up to 220, I believe, 225 maybe. So the way that this became available in the United States is by combining it with Naloxone, Narcan, which Zoe's going to talk about in a minute, which is in the strip itself. It's all mixed up together. And the intent was to block the effect of the injected drug. Okay? So if you take it like you're supposed to, which is sublingually, it dissolves under the tongue, it gets into your bloodstream. It can't be absorbed orally, actually. So if you swallow it, not much gets absorbed. So it's going into those little blood vessels under your tongue, and it's getting to where it needs to go. It's being pumped by your heart to your brain and elsewhere in your body to prevent withdrawal and make somebody feel normal who is dependent on opioids. Naloxone is a blocker. It reverses the effects of opioids. So theoretically, if you gave it with Naloxone, you might not have some of the same effect. Okay. Turns out that's not really true. That buprenorphine has a stronger binding affinity. It binds to that mu-opioid receptor stronger than Naloxone even. And so we know lots of people in clinical practice know lots of people that inject Suboxone. But I think this kind of makes everybody feel a little bit better. I don't know. There's never been any evidence to show that this limits misuse. That said, I always prescribe Suboxone. I never prescribe Subutex unless somebody's pregnant. So buprenorphine, unlike methadone, is what's called a partial agonist at the mu-opioid receptor, and that gives it some interesting pharmacological properties. Overdose is extremely unlikely, and in fact, I've heard repeated that there's never been a fatal Suboxone overdose in the United States ever. There have been people who have died of multiple combined overdoses and have had buprenorphine, the active ingredient in Suboxone, in their systems. But on those kind of reports, you can't really tell what it was. And so all bets are off when you start mixing these drugs. But by itself, and children's brains are a little bit different than adults. And I think there have been case reports of children getting into Suboxone and unfortunately dying. But for adults, no matter how much you take, you won't die. Okay? Many patients prefer this to methadone. So let me talk a little bit about the partial agonist property of this medication. So instead of being the full agonist, instead of giving you the full kind of pain-relieving effect that you might get and euphoric effect that you might get from heroin or morphine or any of the others or even methadone, it's more of to prevent withdrawal and especially in somebody who's used to it, who has a tolerance for it, they don't get euphoric. They just feel normal. Okay, so it's like any other medication that you take for the day. It also has the nice property of being a really, really, really tight binder to that mu-opioid receptor. In fact, so tight that if you've taken Suboxone that day, you can't use heroin. It's not going to get you high. You can, but it's not really going to get you high, okay? Because that heroin molecule can't move the buprenorphine molecule from that receptor. We are in the age of synthetic fentanyl and fentanyl analogs. It's kind of a wild west out there, and there are some exotic fentanyl analogs that can overcome this buprenorphine blockade that we call it. But that's another reason that buprenorphine is a great medication. Questions about buprenorphine real quick? Okay. And of course, you can take it at home. Naltrexone So there have been lots of trials of this, of taking a naltrexone orally every day. It just doesn't last long enough. If you want to get high by the end of like the day or the next day, you can. It doesn't block long enough. An exception might be if somebody was like supervised by somebody taking it every day. I don't know if they've done that study. But so the only version that is actually effective in helping people not use opioids is the Vivitrol, which is a once every 4 week shot. It's a viscous oil, and it goes into your muscle and it slowly releases the medication. Okay, it costs about $1,400 a month. Main Care covers it. Most private insurances cover it. You don't need to take medication every day. This is a blocker, just like the Naloxone that Zoe's going to talk about. And it can prevent overdose, except there have been some studies looking at what if somebody tries to overcome the blockade, especially towards the end of the month. They might take more than they're used to taking, okay, to try and get high, and then they end up overdosing. So there is an increased risk of death there. But particularly within a prison population where in the United States, agonist treatment, methadone or buprenorphine treatment of people with opioid use disorder who are incarcerated, this is more palatable to the corrections system. Those other treatments are rare and not usually available. But giving somebody a shot on their way out the door that's going to help them not use drugs for 30 days, wow. Okay, you're at a really high risk of overdose when you leave prison or other institutions because you've been detoxed. You don't have the tolerance you used to have. Also effective for alcohol use disorder, has been investigated for some other things. It can be quite effective at helping people reduce the amount of alcohol they take, and why is for another talk. But okay, so questions. We have our 3 treatments. Again, we've got the full agonist methadone. The more you take, the more effect you get, even if you could potentially overdose. The intent is to get somebody so, these are high doses of methadone that people take, typically 80 to 120 milligrams a day or more, which is, for anybody in this room, if you're not used to using that, would probably make you stop breathing, or at least fall asleep for a really long time. But you develop such a tolerance that if you take your 20, 50, $100 out on the corner and get that much worth of heroin, it's not going to do enough. It's not going to give you the effect that you're looking for because you have such a high tolerance. Buprenorphine actually blocks some of the effects of those drugs while also being an agonist, a partial agonist, and then that says Naloxone, which is also an antagonist, but Naltrexone as well. Okay, we're at 5 till. Real quick, treatment of other substance use disorders. What's that? Oh, okay. I think a lot of people might have left that had to leave. But, okay. So just treatment of other substance use disorders, alcohol, methamphetamine, and cocaine, sedative hypnotics. There's either not great treatment for them or the adage of that you need medication to treat these disorders is not true, okay? So specifically like for alcohol, CBT is effective. There are studies that show 12-step facilitation is effective, where you go to a therapist and they encourage you to go to 12-step meetings. Anyway, so what I'm talking about applies specifically. Drugs are different, and drugs have different physiological effects, different psychological effects. They're used for different reasons. And for opioid use disorder, it has to be medication. I'm going to skip the case studies and just kind of talk about some of the challenges that I face and that patients that I work with face. Of course, there's a stigma. There's stigma within healthcare. There's stigma without healthcare. Oh, God, he's on Suboxone. He's going to be a pain in the butt. Okay, if somebody's getting admitted to an inpatient floor, something like that. Lack of prescribers and resources. There are nowhere near enough people doing this work as there need to be to treat all the people that need treatment in the state. Insurance. Okay, if people don't have insurance, it costs about between $5 and $10 a day for a regular dose of Suboxone at the pharmacy if you're going to pay cash. Methadone's pennies a day, but a methadone treatment program is about $90 a week if you were going to pay cash. You saw what Naltrexone was, $1,400 a month. So these things cost money and you need insurance. A lot of folks, when they come into treatment, their substance use and the other aspects of their life have progressed to a point to where they're now homeless, so they don't have anywhere to store medication. They're constantly dealing with other people who are using drugs. They're constantly, asking somebody who's homeless to plan to be at an appointment even a week out in the future is kind of like asking them what they're doing a year from now on, Wednesday. Doesn't matter. They can have every intention of making it to that appointment, but it can be very difficult when you are dealing with the stressors at hand to jump through some of the hoops that we have providers place in front of patients. Diversion is always an issue, so if somebody's got medication, they can sell it. Suboxone typically goes in Portland now between $10 and $20 a strip. So if you think about that most people take 2 strips a day, do the math, that's $280 a week, okay? You could pay your rent with that almost. So always something to be aware of. My argument is that if all the people who need treatment are in treatment, the price goes down, okay? The demand goes down. And we do see that in other areas, some metropolitan areas like New York City. I'm told that Suboxone is $5 a strip there. So there's not the pressure to sell it for other drugs, possibly. Speaking of, psychiatric comorbidities, I think are probably pretty obvious. Polysubstance use. If you've gotten to heroin, if you're using heroin, you're probably also using a lot of other stuff. And polysubstance use is the norm and should be expected. And not everybody can quit using all the substances that they're used to using at the same time. Not everybody wants to, okay? And I've got a whole other talk that talks about kind of the how that affects your treatment for opioid use disorder. But things like cannabis, no effect. Yet a lot of treatment programs will require you to stop smoking cannabis. Otherwise, they remove your life-saving treatment for opioid use disorder. They stop prescribing you Suboxone. Even cocaine, there's some literature that people who use cocaine can still be prescribed Suboxone and do well on it. We know they can do well on Methadone. So just kind of something to think about. If people make incremental changes, and going back to the medical analogy, just because I don't want to do anything about my hypertension doesn't mean you should stop prescribing me insulin for my diabetes. It's a completely different thing, okay? Future directions, there's a few new buprenorphine products that just came out on the market this year. One of them's like the Naltrexone long-acting, is a once-monthly shot, but it's buprenorphine, lasts all month, you don't have to take a medication. Looks really interesting. It's subdermal, it goes right under the skin. There's also an implant, that's less interesting. It has to be replaced every 6 months, and it's like the birth control one they have. I haven't seen a whole lot of interest in that. I think we're way underusing Naltrexone, like we're way underusing Methadone and buprenorphine, but I think that's another option, especially long-acting injectable. I'm hoping that when Medicaid expansion in Maine finally gets implemented, hopefully, maybe we'll have to wait until we get a new governor, but we're going to see a lot more people that are eligible for medication-assisted treatment, and hopefully we can save a lot of lives. So that's my part, and I will open it up to questions before I turn it over to Zoe. Yeah.
What's the most common MAT right now? Is it still Methadone, or is it?
As far as numbers go,
Yeah.
I don't have that information, but I could look into it.
What are you seeing most often?
So you're restricted by geography, and so Maine being a rural state where people are far away from each other. If you live in rural Maine, you might have to drive 2 hours to get to your nearest Methadone clinic. That might not be a viable option for you. And so you may not have an addiction specialist or even a psychiatrist or even, there may be one family doctor in the whole town. And so getting lots of different kinds of providers on board with treating opioid use disorder with buprenorphine has been a high priority. Any other questions? That's a good question. Yeah.
No one likes the microphone.
Okay, hi. Yeah, so I was just wondering, I know a lot of programs that try to include counseling and psych assistance, they don't accept people who are currently taking any type of medication. I know Narcotics Anonymous is pretty strict with stuff like that. How do you guys present what you're doing to kind of change that or make a change in those facilities?
That's a great question. So I think it's uneasy, and it's, I think the prospect of being on a medication and maintenance treatment for your addiction is uncomfortable for a lot of people. We kind of, like black and white categories. I hear that it is changing a little bit. I hear that in some, it can vary from meeting to meeting. It can vary between Alcoholics Anonymous. A lot of people go to Alcoholics Anonymous instead of Narcotics Anonymous, even if their drug of choice is not alcohol, for various reasons. There are 12-step programs. Hazelden, kind of the most famous, ritzy kind of inpatient treatment program, which has always been based on 12-step philosophy, made huge headlines a couple years ago when they decided that the evidence was so overwhelming it would be malpractice to not offer medication-assisted treatment for their patients who had opioid use disorder. So, but it's a conflict, and I have patients that are active in 12-step groups because it's helpful to them. They don't disclose that they're on buprenorphine. I'm trying to learn to be open and honest, and yet you can't tell your sponsor about the medication you're on. It's difficult. There needs to be a new paradigm, but we have to work with what we have. Thanks a lot.
Thank you. I mean, and I think also it sounds silly, but like whenever we can talk to the next generation of people who are going to be working with our folks, like that's hopefully going to what's really make a difference at some point. So thank you, Dr. Bonnie. So I'm going to quickly go over overdose prevention and response. This training that I do is how we train our exchange clients all day long. Typically, we do this training about 5 minutes with clients who are in the exchange, so I can talk really fast. I also have different examples of different types of Narcan or Naloxone up here, and if we run out of time for anyone who has a few minutes afterwards, I can show you how to actually do, administer Narcan. And you'll see on my slides it oftentimes says Naloxone, but I tend to say Narcan because that's what most of our clients refer to it as. Depending on where you are in the country, some people call it Narcan, Narcan. There's all kinds of different names for it. But Naloxone is the generic word. Technically, the only one we can call Narcan is the new nasal spray, and I'll show you that. But we'll go over just the real basics. And then for anyone who is interested in learning more about harm reduction or more specific aspects of it, we are going to be having a harm reduction conference here at UNE in the fall. So stay tuned for the date on that, because we're going to bring in people from all over the country to talk about a whole variety of topics. So for anyone who really wants to learn more about this, we will be doing that. So we're going to cover the basics. We're going to talk about what puts people at risk for an overdose. Again, when we're talking about overdose, we're talking specifically about opiates or opioids. Going to talk about how to recognize an overdose and how to respond appropriately. And then we'll look at the different types of Narcan or Naloxone. So risk factors, I think, are important, certainly for anyone in this room, because, again, any single person here has the potential of working with a patient or a client who is at risk for an opiate overdose. I think we oftentimes think of overdose and we immediately think of heroin or fentanyl, rightfully so. That's what we're experiencing right now. But it's also really important to consider people, who are living in like senior living facilities, or our elderly loved ones who maybe are prescribed a pain medication and they take it, they forget that they took it, they take it again, or they don't know that they shouldn't drink wine with it, or a whole variety of things. So it's not just illicit substances that we're talking about, but that's definitely what our community is impacted with right now. So key messages that are really important. Whenever anyone tells me that they're using alone, that's a huge red flag. It's sort of obvious, but of course, if somebody were to overdose and they were alone, there isn't anyone there to respond to them. This is a big one, though. For a lot of people, using alone is part of their ritual, or there is a very specific reason why they are using alone. They've relapsed and they're hiding their use. They are ashamed to tell anyone. For whatever reason, they are choosing to do that. So that can be a really hard safety message to talk to people about. And I can't say that I've made huge progress with people. Sometimes, like, making a really intense statement to kind of get them to understand what that would look like if something were to happen helps. But really, for people, it's like if they're using alone, they're using alone. Mixing substances is a big one. Polysubstance use, I'd say the majority of the clients that we see in our program are polysubstance users. Heroin and cocaine are, as old as time. New drugs that are big sort of offenders with heroin and fentanyl use are benzos, which have been the case for a while, things like Xanax, gabapentin or Neurontin, widely available on the streets. And taken in large doses, and they sort of mimic the effects of a benzo, especially when taken with opiates. So that's a really big one. But even stimulants, other stimulants, crystal meth is making a huge comeback. And when looking at cocaine, like stimulant use with opiate use, it's changing the effects of the opiates. Oftentimes the person is then taking more than perhaps they intended, and that can cause an overdose, of course. And Dr. Bonnie mentioned this, the tolerance piece, and we see that people coming out of detox. There's not enough resources for people when they leave a treatment facility or a detox unit, and there's only one in the state. So when they leave Milestone, we actually are on the same street as Milestone. So I see a lot of people come right from Milestone to the exchange to get supplies, which is great. I wouldn't want them anywhere else. But they're at a huge risk for overdose because their tolerance has been lowered. They haven't had opiates in their system for maybe 3 to 5 days. And everyone is very confident that they can handle their dose, that they know how much they can use, they know how much to use safely, and everyone has that intention. It is very rare that we see intentional overdose in our program. But for the most part, people really think that they can handle how much they had used last week or yesterday or whatever it was. And I get a lot of reports, people coming back and saying, I'm glad you gave me that Narcan because after I left, I overdosed. So when we know that's happening, we make a safety plan, like who are you using with? Do you guys have Narcan? Gosh, I wish we had a safe injection facility for y'all right now. Being careful about changes in quality, and this really is the presence of fentanyl and other synthetic opiates on the streets. This is definitely what our community is experiencing. You're hearing about it in the news, you're hearing about it everywhere. When fentanyl hit the streets of Portland about 2 years ago, everything changed. All of our messaging had to change. We had to look at everything differently. A heroin overdose, like real heroin, it usually happens like 1 to 3 hours after use. With fentanyl, that is not the case. So the overdose itself is much different, and we'll look at that more. And then being mindful of health. So we see a higher rate of overdose among people who are homeless or transient. Dehydration, malnutrition, not getting enough sleep, all of those things can affect somebody and their risk of overdose. So recognizing an overdose, being mindful that what you are looking for or what you are looking at is a respiratory emergency. So somebody who's not getting enough oxygen and is slowly going to stop breathing. Whenever anyone uses opiates, their breathing slows. But when they overdose, their breathing slows even more. So typically with an overdose, the person is getting less than 8 to 10 breaths per minute. So you're going to see things like blue lips, blue fingertips, cold, clammy skin, of course, pinpoint pupils. But the general thing that is going to make you know that it is somebody who is overdosing versus somebody who is just very high and under the influence of opiates is the fact that they are not responding. So it is very common with opiate use to have somebody who appears very sleepy, looks very tired, muscles are relaxed, but they're answering you when you shake them or you call their name or you say something to them. When somebody is overdosing, that's not the case. You're not going to get any response from them at all. So this slide I like to use just to kind of show the difference. Some people have no concept of what somebody looks like or acts like when they're high on opiates. And so this stuff is very normal, you know, the relaxed muscles, the nodding out, which is like the opening and closing of somebody's eyes, looking like they're kind of sleeping. But they're going to respond to stimulation. So the first thing that I do if I'm concerned that somebody is overdosing is I do what's called a sternal rub, which is rubbing your knuckles hard and fast on their breastbone. And that does hurt if you do it hard enough. And sometimes people will come back and show me, you know, they'll lift their shirt up and tell me that they just overdosed and their whole chest is just rubbed completely raw, black and blue. It's a good way to continue to try to elicit a response while you're responding, but it's a good thing to do quickly right away. If somebody's passed out because they're drunk or they're just sleeping, they're gonna respond to a sternal rub. But the overdose is really gonna look, you know, the breathing is gonna sound very distinct. It's a very deep snoring sound, a gurgling or wheezing, and then, you know, they're not going to be awake. And the color change is really intense. I mean, I can't stress enough that with fentanyl, the color change happens really, really fast. And so I've had people come back and say, you know, I didn't think there was any way that the person was going to come back. You know, they turned blue so fast. I just assumed that they were dead. And so that's something else that we're seeing that's different between heroin and fentanyl. I think it's important to understand how the overdose occurs and why it's so important to react quickly. Because you're dealing with somebody whose oxygen levels are decreasing, you know, that chance for permanent brain damage is very real. We definitely have people who we see who have experienced so many overdoses that memory loss, vision problems, speech issues are very real. They were left without breathing for so long that there's effects from that. So responding as quickly as possible. I mean, if every overdose was responded to while the person was still breathing, it would be a wonderful thing. Because it's important to know that once the heart stops beating, Narcan or Naloxone is no longer effective. Our response and the way we train people as bystanders is obviously different than a medical response, but it's very straightforward. We encourage everyone to call 911 first and foremost, and then either while they're doing that or right after they do that, give 1 dose of Narcan. Regardless of which preparation you're going to use, you give 1 dose and then you wait a couple of minutes before determining if the person needs another dose. Now, this was a message that really got lost in the hysteria of fentanyl, where it was sort of like, just keep giving them Narcan, just like hit them a bunch of times because it's not going to kill them, which is true. I mean, Narcan is an incredible medication. You can give somebody a lot of it and they are not going to be injured by that. But it's also not a very humane response. So we really try to give the person the least amount of Narcan possible. And this is a different message than you're going to hear from other sources. I mean, I just saw it in the paper last week, like, well, it's better to give too much than not enough. No, that's not really true. You want to give them the least amount of as possible. It will ensure that as they wake up, the situation is as less complicated as possible. The person is going to wake up gently. They are not going to feel really sick and uncomfortable. And you know, you're not going through 10 doses of Narcan. So give 1 dose, wait a couple of minutes, see if they need another one. If they do, then you would give that one. By that time, 911 will be there, the first responders will be there, they will take over. They will decide if they want to give more. A lot of times they don't, they just ventilate the patient, which is the appropriate response. Stay with the person until they wake up. Here in Maine, we don't have a Good Samaritan law specific to overdose. And so it comes up a lot where if you asked a paramedic, do we have a Good Samaritan law? They would say, yeah, we do. But we don't have a Good Samaritan law when you think about, you know, places like Massachusetts or Vermont, where if somebody was at my house and they, used some heroin and they overdosed on my couch and I called 911, it's possible that I could get in trouble for that heroin that was left on my coffee table. Or if I was on probation, or there were like, you know, other things happening, I had children in the house, whatever, yeah, I would definitely get in trouble for that. A Good Samaritan law in reference to overdose protects the person who is calling to report the overdose if there was a small amount of heroin or other substances present at the scene when the first responders get there. That's it. It doesn't cover all of the other things, the probation, the children, all of that, or if there's like large amounts of heroin and you know, trafficking material. It's just for small possession. So we don't have that, but what we do have is a medical Good Samaritan law. And a medical Good Samaritan law protects anyone who's acting in good faith and responding to any kind of medical emergency, not just an overdose, but like anything like car accident, heart attack, you know, somebody's choking. If you kind of try to respond and do the right thing and that person were to die, you would never be held liable for that. And so thinking about bystander naloxone, you would also not get in trouble if you had naloxone, responded to the overdose, and the person died. So it's important to know the difference of those two things. So this has been coming up a lot, I think, in the media, and it's not over. People are still talking about it. It's this belief that this transdermal absorption of fentanyl, there was a couple of police officers and a couple of first responders who claimed to have overdosed when they responded to an overdose scene, and they touched fentanyl, and then they got so high and they overdosed. And what we harm reductionists like to say is that if everyone could get high from just touching fentanyl, nobody would need to inject it. But these are some sort of like more medical sounding responses. But basically it's not true. I think the belief also came from, you know, fentanyl, what we know of fentanyl, or what some people will think of fentanyl, is the transdermal patches that are used for pain management, or used to be used for pain management, which is not what we're seeing on the streets. What we're seeing on the streets is laboratory-made, powdered, synthetic opiates, fentanyl, and a whole bunch of other ones. You know, it's not pharmaceutical grade, it's not coming from a hospital. I've been shown websites where you can buy it and it's shipped from overseas and comes here, and it's being mixed in bags of heroin and being sold on the streets as heroin. It's much stronger, but it's also a common misconception that because it's so much stronger, you need more Narcan to reverse the overdose, and it's not true. The affinity on the brain is not any stronger than heroin is. And I think that that's important because when you're looking at what the overdose is really going to look like, you know, I said the color change happens a lot faster. The overdose itself happens almost immediately. So a lot of times people are dealing with other things like, you know, paraphernalia at the scene. A lot of the times what we deal with now is like when an overdose is responded to, there is oftentimes still a needle in somebody's arm or a needle present at the scene. You know, the overdose is occurring almost instantly. Our old messages always used to be, you know, do a tester shot, do a tester amount, test the strength of your product. You can always do more, you can't do less. People are overdosing on their tester shots of fentanyl. So it's a very real thing. And it's not like quality mixing is happening. Wherever the mixing of the product is happening along the distribution lines, we call it the chocolate chip cookie effect, where like within the bags that are being sold, you know, there's like chunks of fentanyl almost throughout. So you know, we'll get reports of people splitting a bag with two friends, two people overdose, the third person's fine, all from the same individual bag. There was also a case a couple years ago where there was a seizure and DEA tested the individual bags that the dealer had, and there was probably 25 different bags, and they ranged from like 4% fentanyl up to 98% fentanyl, and the dealer had no idea. So wherever that is happening, it's well before anyone's getting their hands on it and distributing it on the streets of Portland. But it's almost impossible to find heroin at this point. Almost everything has some amount of fentanyl in it. And not everyone, there's a lot of places, different intensive outpatient programs and Suboxone clinics, Methadone clinics, probation. Not everyone is testing for fentanyl when they're doing urine tests. So, people are passing their urine tests sometimes with flying colors because people aren't testing for fentanyl because it's another test. So just little tidbits of information. Okay, so when you're looking at naloxone, there's a couple of different preparations, and I brought examples of each, so feel free to come up after and take a look at what we have. There's, sort of on the far left, there is the multi-step nasal kits. These were available in Massachusetts forever. It's a good preparation of naloxone. It's a intranasal preparation, and the kits come with a little atomizer device to make, turn the liquid into a spray. This goes up both nostrils, and it's absorbed in the mucosal membranes of the person's nose. So they don't have to be breathing, or they don't have to breathe it in. It just absorbs. Takes a couple minutes. It's a very gentle wake up. We like that. The middle preparation is intramuscular syringe and vial naloxone. This is what we started with in our program in 2015, and this is actually what we've gone back to now. There is not a lot that's available. It's become very expensive. I don't have funding for this portion of my program, so I rely on donations in order to have it for our clients. So this works for people who are comfortable drawing up a solution into a syringe and giving an intramuscular injection, which most of our clients are fine doing that. It works great. Again, the vials are small, they're 1 cc. A lot of people report that they will do half a vial and then do a little bit more. Again, that's great. It's a gentle wake up. That's what we like. Purple and yellow, these are the auto injectors. This is what we always used to have. This is a 0.4 milligram intramuscular injection, and 2 come in the box. Again, that's a really nice, gentle wake up. They discontinued this preparation, the pharmaceutical companies, and they only have a 2 milligram injection per device. And to us, we feel like that is way too much Narcan to be giving somebody. 2 milligrams is a lot. Most of our clients are comfortable giving 0.4 and then another 0.4 and maybe even a third. But 2 and then another 2 and then potentially more, that's a lot. The more Narcan somebody is given, the greater the chances that they are going to report withdrawal symptoms when they wake up. Those opiates are being blocked in their brain. And if they've been given too much Narcan, they're really going to feel like they would if they didn't have any opiates in their systems at all. So dope sickness, withdrawal, whatever you call it, it can be really, really intense, and it can complicate that whole response, especially for a bystander who's just responding because they happen to be walking by, or a friend who's doing the right thing. It can just make it really unpleasant. So we were really disappointed to hear that they discontinued these because we love the auto injectors. But until there's data directly from people who use drugs showing that the 2 milligram auto injectors are not causing intense withdrawal symptoms, we're not willing to risk it. This is the new intranasal Narcan. This is one I said that you could only really call Narcan. This is what Portland police officers carry. This is another really good preparation. This is a 4 milligram nasal spray, so it is a big dose of Narcan, but it's being absorbed intranasally. So again, it's still a pretty gentle preparation, but you can be almost certain that you'd only need to use 1 of these. 2 still come in the box. This is what's most common at the pharmacies. Most of the pharmacies are stocking this preparation. Most health insurances will cover this preparation. Main Care covers this 100%. It's really, really easy to use. I would love to give it out. I just can't get it for free. And just quickly, this is how naloxone works. It's a temporary block. So, I have people come and ask me, is this going to clear the opiates out of their system? Maybe they have probation the next day, for example. And no, it doesn't clear the opiates out. It just temporarily blocks the effects. So after about 30 to 90 minutes, the Narcan wears off and the effects of the opiates are potentially still there. Especially with fentanyl, the half-life is short, but it's longer than naloxone a lot of times. And so if they do experience withdrawal symptoms from their overdose, once the Narcan wears off, they might not feel so uncomfortable. So important things to remember, just stay with the person. It's really important not to leave somebody alone who's overdosing. Continue to wake them up if you can, if you've given them Narcan and you're waiting for the first responders to arrive, and know that those withdrawal symptoms are a possibility. So if they are feeling really uncomfortable when they wake up, just try to remind them that it's not going to last forever, that they're not going to feel terrible, that it will wear off. Of course, try to discourage them from using again right away. Sometimes that desire to use is very, very strong. And encourage them to go to the hospital if they will. People in Maine can refuse medical transport, and a lot of people do. A lot of our folks don't call 911. About 30% of the time they're calling. The rest of the time they're handling the overdose on their own, which you can look at that a variety of ways, but most of our clients feel very comfortable reversing overdoses at this point. This is a good position to utilize if you were ever responding to an overdose alone. It's important never to leave anyone flat on their back. Sometimes people vomit or, there's fluids in the mouth. You wouldn't want them to choke. So if you have to leave the person for any reason, just roll them into what's called the recovery position. Knees are bent to support the weight of the body, head sort of tilted down on the person's arms. And this comes up a lot when we're talking to clients, when we try to honor the stories of what people tell us, because a lot of people have been reversing overdoses well before we had access to naloxone. And so we don't, even though some of these sound ridiculous or crazy or like, why would you ever do that? This has worked for a lot of people. Every single one of these, somebody has told us they've done. Especially we get the cold shower, put them in a snowbank, ice down their pants. And all of that can actually be more harmful than good. But for someone, it worked. And so they come, they're like, I've always done this. And, and that's great. But it just wastes time. If you have Narcan, just give them Narcan as quickly as you possibly can. And so where we're at right now, we've made some progress here in Maine. Any person can get a prescription of Narcan from their doctor. You don't need to give a reason why, you don't need to prove that you need it. It does not need to be attached to a diagnosis, but anyone can get a prescription. So if you're interested in carrying Narcan just because you want to, and you have a primary care doctor and you have health insurance, by all means do so. Most of the pharmacies carry it. Walgreens, you can actually get it without a prescription. That is something they chose to do on the national level without waiting for the state law to kick in. Right now, the way that it is our governor has passed a law to allow for over-the-counter distribution of Naloxone. You have to be 21 and older. I have no idea what that's going to look like for bystander Narcan or people who get it from the exchange or people who get it from their doctor. You don't have to be 21 for any of those things. So we are still making progress, but I have a lot of people asking me how they can get it, and it is quite easy to get it. And the more people who ask for it from their doctor, the more doctors who are going to be willing to write prescriptions for it. Any questions? Yes.
So I went and did my first undergrad in Vermont, where they have a Good Samaritan law. Mm-hmm. Is there any type of legislation that's going through Maine to kind of put that in effect for people? Do you find that to be a barrier to people kind of calling 911 to get assistance?
Yeah, there has been bills presented in the past. I think right now, the groups that have been presenting those bills are kind of choosing to wait a little bit, that it sort of just they haven't passed. I think that there is so much stigma still associated with calling 911. A lot of our folks aren't calling because they're on probation, or they get assistance with their housing, or there's children in the home. Like, there's other reasons that I'm not sure a Good Sam law would cover, but I think it would still be a step in the right direction. I think, I'm hoping in the next couple of years it will be presented again. Yeah. Other questions? Yeah. Yeah.
I just know that it's often hard for them to get medical assisted treatment, and that, like you said, a lot of clinics make them do the counseling, which they can't do with their work schedule usually because they're out at sea. So I don't know if, I just didn't know if there's any work being done about that, or
I
what your
send all
thoughts
my
are.
fishermen to Dr. Bonnie. Okay. No, it's a huge thing, and I think you know, I'm going to the Fishermen's Forum next week up in Rockland, which I'm really excited to do, and doing some Narcan trainings up there, which is a big one. I come from a fishing family here in Portland. The community is deeply impacted by opioid use, and it's really, really hard, because if you want to be on methadone or you want to be on Suboxone, you better hope that you have a doctor who's going to write you that 12 to 14 day script and trust that you're going to take it. It's a hard one.
Something that I've looked into is getting a third party on the boat to be involved in the treatment. Of course, that would be, you know, voluntary on the patient's part, but they would sign a release. Having a third party can always be helpful, involving family in treatment. And I, as a prescriber, I'd feel a lot more comfortable if the captain was looking after the supply of Suboxone, and that it's not all, you know, getting sold for drugs when they come into port or whatever.
Other questions? Okay. So I've got some Narcan kits up here. I don't know, do we have to like be out of this room? Okay, so anyone who has a couple minutes, I certainly do. We've got these cool things. We can practice injections. I'll show you how to use them. I've got brochures and other information up here. So thank you.
And the multi-step is cheaper, it's like $60, and then the single step is more like $120 out of pocket right now, which will be less.
The question was how much. The question was how much does Narcan cost over the counter at Walgreens?
Right. Yeah. So it does vary. Okay, so I'm in Untitled Chapter, and I was curious if you guys saw in our city, we like track the overdoses and the surge, and they send out like yes. Everyone, do you still do that here? We are working on that. Okay. Yeah, we're really hoping that we're trying as a city to have all of the overdose reports come into public health, and then we as a public health division will make that determination. We track all of our overdose reports. You know, anyone who uses one of our kits and reverses an overdose, they come back, they tell us about it, we get a report, and we track that. So that's how I know, you know, we reversed 291 overdoses last year. But on the city level, it's much harder because it's like a different data collection system for fire and for police. So that's a huge focus for us this year.
Yeah, because we have this coalition where it's like all of EMS, all of fire,
we're
all
all
of
trying to
police.
be like mass all the time.
I thought it was interesting. I didn't realize that there's this sort of discrepancy.
Like
everyone was called.
I know.
You just go and care. Yeah. You get the call, but we also have like a project to care. So if any EMTs or police see like a child or signs of a child,
Yeah, I know. It's we're still trying to get the data piece a little bit tighter for sure. It's important. And they were talking about injection sites, right? I've seen that in the last couple of years. Yeah, I think that, you know, nationwide people are starting to explore that, and I was happy to hear that a couple of our councilors are interested in it. We're going to be holding a community forum regarding safe detention spaces March 26th or 8th. I have to look at my calendar. But it's going to be at the library. We're just going to try to have, open forum, providing education, and trying to really, I think I see our role as a public health division being pillars of education and providing that information. So if our city councilors want to know more, want to be a part of that, that's amazing. So yeah, that will be coming up very soon. Okay, so we have a couple of different preparations, and these are both the intramuscular preparations because I think the intranasal preparations are so easy to use. You really don't need to practice them. But for anybody who is never maybe going to give an intramuscular injection, it can be kind of daunting because, these are intramuscular syringes. We design, we want them big enough so that people can put them right through the person's clothing, right through the jacket, pants. So the needles we use are 23 gauge, 1.5 inch syringe. And so sometimes, people will open it and it's like a really big needle. So what I usually advise is when you first open it, make sure the needle is tight on the barrel because sometimes it will loosen, especially if it's like kept in somebody's bag or it's kept in your backpack or whatever. And then one of these vials is one dose, it's 1 cc. And so everyone kind of does this differently, but really the easiest way to do it, you take the cap off the needle, and just take the cap off this first so you don't accidentally stick yourself. Put the needle right in, draw the plunger up, stick the needle in, make sure it's right in the solution, push the needle down, and then it will kind of create a vacuum. So it'll really easily just draw all the solution up. And because you're dealing with an emergency, so a couple of drops left in there, you don't have to worry about that. Then make sure, you're going to see it's about 1. Again, doesn't need to be exact. And then this is just an intramuscular injection that's going to go into a large muscle. So ideally, you're going to try to get the large part of like the glute or the thigh or the arm. And it's just a 90-degree angle right in. So people can practice drawing this up. And I've got a couple of different kits here. And then we also have these little devices. Can we put liquid into this? Mm-hmm. Yeah? Okay, cool. So we can, I was thinking about that, I meant to ask you that before. So these are little injector pads from the nursing department. So you can actually try putting it right in and injecting it right in. And these are all expired doses. So I brought them for everyone to try. And then the other option for trying, these are the training devices for the auto injectors. And so these mimic exactly what the active doses do. These are really great. This preparation goes into the side of the person's thigh. So again, you can use one of these. There's also no needle, so you can use it right against your own thigh if you want to as well. And they talk you through the process of what to do. So when you open them, you'll hear that they activate. So feel free, if everyone wants to either grab one of these or grab one of these. There's a couple of needles in each package, and we can kind of do it right here. Or if you want to do the auto injector and you want to hear it really well, just maybe go over to the side or something. But I'll take a couple of these out for people. Again, I always keep gloves in the kits. Of course, that's always best practice. Most of our folks are not probably using gloves. Yeah, you're welcome. So, if you have a couple of fancy fingers, yeah. I've never done it, so I'm going to do it. Oh, cool. What is your background? Yeah. So my background is not really anything really related to this. I didn't go to school for healthcare or anything. I went to school for sociology and then got into harm reduction just by starting to work at our clinic on India Street, and just kind of when I started working in the exchange, we received 450 people a year. And I'm from Portland. I know there's a lot more than 450 drug users in Portland, so it was sort of my goal to increase enrollment. And so from the first year that I was there, which was 2010 to 2011, we almost doubled our enrollment. Oh, wow. So my whole focus was really kind of just like get the word out there, do outreach, do education. I know a lot of people use drugs in Portland, and I wanted to really just make it a place that like felt really safe and comfortable for people to come to. I just learned a lot as I went.
That's awesome, because I was really interested in like public health.
Yeah.
Like, sorry, nursing. I just wonder if you like
Public health nurses
Yeah.
are awesome. They're the best. Yeah.
Is there one that you find like more effective or better?
Not really. I really like the auto injectors. They're really easy. Our clients are really comfortable with the auto injectors, but when people come back and they've done a reversal with the IM needle, they actually say they feel like the person's overdose reverses faster, even though it's the exact same amount.
Yeah.
But I think the difference between like the thigh and right into that large muscle can really make a difference for somebody. Some people also, like I said, I had a couple that I saw last summer, and the woman would overdose almost every single time they used together. So he would draw up half a vial before they used, so that by the time she did her shot of heroin, and then he did his, she was almost overdosing, and he would be ready to like reverse it right away. She was really.
I just want to ask you, so I'm not holding this.
Yeah.
So I just like I can you
Yeah.
like put into it.
Yeah.
Okay. So do I do like?
Yeah. Just stick it right in. Yep. And then press it.
So do you stick it in like all the way?
Yeah. Yeah. That's good.
Like right up to that. Okay.
Yeah. I mean, and again, like if it was somebody who was really thin, I maybe wouldn't, I wouldn't stick it in all the way. I would just, try to use your best judgment. But ultimately, if somebody is a little bruised but they're alive, it's not ideal, but it's not bad.
Are there any programs around to just like have Narcan at lower cost? I don't know. I would just like it for more people just like for bystander reasons to have it, but it's just I'm glad that you has it, but that's still pretty pricey.
It's super pricey. Yeah. So what I would say, it's like $100+ if you don't have your insurance. That's for 2 doses of the new nasal Narcan. So at Maine Med, for example, they have a free care program for people who, meet certain like income qualifications. And so Narcan is available at their outpatient pharmacy. So for somebody who was enrolled in their free care program, they would be able to get it for free at Maine Med's outpatient pharmacy. It's also offered to anyone who presents at the emergency room with like an opiate-related emergency. So whether it's an abscess or a soft tissue infection or an overdose, they're offered Narcan before they
You said it's covered and that doctors can prescribe it without
Yeah.
diagnosis.
Yeah, and there's still a lot of education to be had. We just finished training all of the Maine Med family practice locations. And even after that, I got feedback from a client and said that their Maine Med doc, was like a little nervous about writing them a prescription. And so, but because I made that connection, I was able to then call the clinic and just kind of walk them through. Because I think it is hard for doctors to wrap their heads around knowingly prescribing a medication that is going to be used on somebody other than the patient they're prescribing it for. Like, that's a big one for them. But that's what it's intended for.
No, I'm gonna talk to my doctor about it.
Yeah, and that's what I mean. I feel like the more of us that just like ask our doctors and have the education to know that like it's okay to advocate and like no, I don't need to tell you why or who it's why I want it or what I need it for. And if you have health insurance, the coverage is pretty good.
Is that only in the doctor's
Well, it depends. I mean, other states have way better access. New York, I think you can walk in anywhere and just get it.
Oh,
Yeah. You can also get a prescription from your doctor, but yeah, our access is definitely less than a lot of other states.
what do you see for kids for like juveniles? I just like I work in school.
Yeah.
So I'm wondering like, have you done a training with like?
I trained all the school nurses in Portland, which was great. And they're
School research officers.
yeah, that's something that I have to circle back around because that just came up last week, and I thought of that too. I think that
it's definitely more acceptable in the high schools, of course, than like in the middle schools. But even just like I want to teach the kids how to respond to an overdose. You know, there was a whole movement. I think it was the Clinton Foundation made all of this money available to put Narcan in all the high schools across the country, and so I think I'm not sure if that's what Portland ended up doing. But I know that there is financial assistance available for the high schools who want to have Narcan. Because I think, again, it's really important just for everybody as a community, like, to know how to respond. It can be so easy, and oftentimes the first responders are the people who are right there when the overdose happens. So either friends or family members or people walking down the street, you know? So, all right, I'm going to try this. I know.
I didn't know if you were.
No,
I can use this one. Thank
Yeah.
you so much.
Yeah, you're welcome. Thanks for coming.
Can I do that again?
Yeah. Oh my gosh.
We like just learned about doing intramuscular injections today. So yeah, that's like pretty cool. So.
Yeah. So I usually put the plunger up to 1 first to create that vacuum.
So you do that before you
Some
put it in.
people don't do that though. They just put right in. So you can try both ways and see which feels better to you. I try to have everyone, when they get a kit in the exchange, to try it out at least once, because even people who are really comfortable, injecting solutions, it's still, it's a little different, unless we do have some people who use steroids. So do you usually do this?
I'm a social worker.
So yeah, you can even like do it like this, and
Like
kind of
this.
and then
Go slowly.
yeah. Yep, and then yes. Although what I tell people is that when you're dealing with a Narcan injection, don't worry about the edibles. Yeah, that's going to be more important with like an IV injection.
Is this like similar to actual?
Yeah, we got it from the nursing department.
To like
Yeah.